Recording. All right, everybody, this is Dr. Messersmith. He's going to talk to you about what he does, and I'm going to stop my video. Enjoy.
Well, thank you so much, Chris. It's a pleasure to speak with Cherry Creek High School, where my daughter is a student. My name is Wells Messersmith. I'm a medical oncologist, and I'll be speaking to the class today about diagnosing and treating cancer. Just a little bit on my background. So as a medical oncologist, I'm basically focused on chemotherapy and immunotherapy treatments for cancer. And I work very closely with surgeons, radiation oncologists, and others to take care of patients. My initial training is in internal medicine after medical school, and then I did a specialized fellowship in medical oncology. And I've been here in Colorado for about 13 years. After being on faculty at Johns Hopkins prior to moving here back in 2007. So let's start with the basics. What is cancer? So the hallmark of cancer is basically uncontrolled cell division. So when you're growing from a baby to a grown person, that cell division isn't random. That's actually very carefully controlled. Cancer occurs when you have basically cell division that's out of control. And there are many, many different cancer types. You know, when people talk about, are we going to find a cure to cancer? My reply is to what cancer are they referring to? Because there are so many different kinds of cancer that have many different etiologies and growth pathways and patterns of growth and patterns of spread that even while we've made tremendous progress in one cancer type, we might not make one in another. And cancer cells basically can spread to other parts of the body, often through the blood system and also through the lymph system. And there are multiple types of cancer. Carcinoma is the most common type, and that occurs in skin or in tissues that line or cover internal organs. And so you can think of those as actually the tissues that face the outside world. So your skin, your lung, you're breathing in things. This is why there's so much concern about vaping in teenagers and smoking, because your lung cells, the lining is just getting pelted with carcinogens. Breast cancer, prostate cancer, those consist of glands. And the colon, of course, is exposed to things that you eat. Sarcoma, on the other hand, those are cancers that begin in areas of the body that have no exposure to the outside world, bone, cartilage, fat, muscle, etc. Leukemia starts in bone marrow, and actually leukemia is one of the more common types in teenagers and in children. And then lymphoma and myeloma begin in cells of the immune system. Leukemia is also immune system as well, but lymphoma often begins in lymph nodes, and myeloma will often start in bones. So what causes cancer? We really think of it as the intersection of three things. The first is genes that you're born with, and it's estimated actually that probably only about 10% of the cancers that people get are related to specifically their genes. Environmental toxins play a big role. So if you smoke, for instance, you have a 13-fold higher chance of getting many different cancer types. Here in the state of Colorado, we're exposed to a lot of radiation, and we do have higher skin cancer rates. Your exposure goes up about 6% per 1,000 feet. So if we're at 5,000 or 6,000 feet, you have about 30 to 40% higher exposure to radiation. Viruses are quite common causes of cancer, diet, etc. But probably the major player is bad luck. We have 25,000 genes approximately, made up of 3 billion base pairs. And if you happen to get a mutation specifically in a gene that controls cell division, and specifically in a part of that gene where the mutation, let's say, makes a cancer-causing gene more active, that's when you get cancer. So it's really two layers of bad luck. You get a mutation in the wrong gene and in the wrong place in that gene. And so that's where luck plays a role. So how big of an issue is cancer? Well, in 2020, it's estimated there'll be over 1.8 million new cancer cases, and over 600,000 Americans will die from cancer. So that's about 1,600 per day. 1 in 4 Americans will pass away from cancer, and the good news is that nearly 17 million Americans are alive with a history of cancer, and that's more than 3 times the population of Colorado. So there are a lot of cancer survivors out there. Cancer survivors often require somewhat specialized care because of the prior treatment and also being at risk of other cancers, and so it's something that we in the medical community have to pay attention to. And we also, in fact, have a clinic called the Tactics Clinic, which is a collaboration with Children's Hospital, where we take care of children, including teenagers, who have been treated for cancer. So this is a map, and I would direct you to the American Cancer Society. The American Cancer Society publishes a publication called Cancer Facts and Figures every year. So this is from 2020. Of course, 2020 is still going on, but these are basically estimates of cancer incidence and death rates across the entire United States based on decades of statistical modeling. You can see in Colorado in the middle, we have approximately 27,000 cases of cancer per year. Of course, if you compare us to a state like California, which is huge, they have 172,000 cases, and a smaller state like Wyoming only has 2,800 cases. So you can see how the case rate sort of mirrors what the general population of this state. Colorado is one of the fitter states, actually. We have fairly low obesity rates, fairly low smoking rates. So actually compared to our population, our cancer rates are relatively low compared to other populations that have major smoking rates and obesity rates. So this is a figure and table basically showing the estimated new cases and estimated deaths. And it's sort of worth taking a few minutes here to unpack this. Again, this is from the American Cancer Society. You can Google this and get this from Cancer Facts and Figures. And they separate males to the left, females to the right. And of course, there's some cancers that are specific to a certain sex. So prostate cancer tends to happen in males, and breast tends to happen in females. Some occur in both. So lung is the #1 cause of death. If you come down to the deaths here for males and females, you'll see that lung cancer is by far the #1 cause of death. And then that's followed by the cancer that's specific to that sex. So men have obviously death rates from prostate, and women from breast. Some men do get breast cancer, but it's extremely rare and not a major site of death. The #3 for both incidence and death is colon and rectum. And you can start to get a sense of how deadly these cancers are compared to how many people are walking around with them. So for instance, prostate cancer, you have 191,000 cases, but then you're down to 33,000 deaths. So that's a lot more diagnoses than death, and it tells you that many people with prostate cancer die from other causes. If you take something like pancreatic cancer, pancreas cancer, you see that in males, you have 30,000 cases, and unfortunately, it's the #4 cause of death, 24,000. So the ratio of cases to death is actually close to 1 in the case of pancreas. Same with women. Pancreas cancer, 27,000 cases, 22,000 deaths. So there, the incidence, meaning how many cases are diagnosed, and the deaths are fairly similar. Breast cancers like prostate, there's a lot of cases, 276,000 cases, but you're down to 42,000 deaths. And so you can see that the ratios of your estimated new cases to deaths is quite variable. And these numbers have been fairly stable. Pancreas will probably overtake colorectal in the next few years as the number 4. And of course, if you take out prostate and breast, which are sex specific, it would then go up to the number 2 cause. Liver and bile duct cancer, leukemia, esophageal cancer, bladder cancer, lymphoma, as we talked about, and then brain comes in a distant third here. So these are just interesting statistics to consider for the whole country. If you look at cancer death rates over time, again, this is from the American Cancer Society, it's sort of interesting to think that in 1930, one of the more common causes of cancer death in the United States was stomach cancer. And now that is actually a fairly rare tumor type. Same with liver. Liver has kind of come down, kind of bottomed out in the 80s, and then the hepatitis C epidemic hit, and now it's kind of coming back up again. A cancer like pancreas has kind of slowly risen over time. And once we started to see smoking rates go down in the 80s, there was kind of this peak. This, by the way, is in females. There's this peak, and now that's finally starting to go down, and breast cancer is starting to go down. So as you sort of see these interesting patterns, if you look over the last 90 years of cancer data, we don't know why stomach cancer, for instance, became rare. It's thought to be in part related to refrigeration and maybe food preservation techniques. It's also interesting to consider that in some countries, like in many Asian countries, stomach cancer is one of the more common ones, and they don't get colonoscopies because colon cancer is quite rare. They get upper endoscopies to look for stomach cancer. And then within one generation of immigrating here, their patterns switch from stomach to colon. So there's something about the way we live and our diets and et cetera, where someone from Japan, for instance, within one generation will switch from a stomach pattern to a colorectal cancer pattern. But here you can see sort of these overall trends. You know, the good news is most of the cancer incidents and deaths are actually going down. Many people will say, well, wait a minute, we have more cases though. Well, that's true. You know, the US population is growing, but cancer incidence rates, in other words, the rate per 100 million people or what have you, those are actually going down. So if someone tells you, oh, cancer, you know, skyrocketing, that's not really true. In fact, most of the cancer rates are actually going down. What about teenagers? So if you look at people who are 15 to 19-year-olds, you'll see that the cancer types are actually quite different from adults. So first of all, the number of cases is much less. As I mentioned, there's over 600,000 cases in the United States, and for 15 to 19-year-olds, 5,800. So a much lower rate of cancer. It does go up as you start getting into the 20s and 30s, and same with deaths. And then if you look at the cancer types, and you look at the size of these bars, you see sort of a different pattern here. So lymphomas, for instance, are more common in younger people. Same with leukemia. You can see leukemias are greater in 15 to 19-year-olds, and then as you get to your 20s and 30s, those tend to go down. You start to see a breast cancer signal in the 20s and 30s that wasn't there in younger kids. Brain tumors are more common in children, and then they go down as you get into your 20s and 30s. So you can see there's these sort of different trends for teenagers and young adults than for the folks who are older. What about cancer prevention? So it's thought that about 40%, more than 40% of cancers are avoidable. So about 20% would be avoided if people stop smoking. There's a lot of studies going on now about vaping, because vaping is a relatively more recent phenomenon, and we're not sure what the cancer causing properties are. And then obesity is a big one. So excess weight, inactivity, poor nutrition, excess alcohol, all of those also lead to cancer. And so if people basically stop smoking and maintained a healthy weight without excessive drinking, you know, over 40% of cancers would be avoided. Skin cancer is quite common, and skin cancer obviously is a big problem here in Colorado. It's a sunny state, but the problem is that there's a lot of sun exposure, and so skin cancer rates are actually higher here versus other places that are more cloudy. And tanning salons have been associated with excess skin cancer rates. So that's one thing to be aware of, is just if you get a peeling or blistering sunburn, you just increased your cancer risk significantly in your skin. And then finally, screening. So screening is basically doing a test on an asymptomatic person. So they feel perfectly fine. And you do a test to see if they're at risk for getting a cancer. So there are screening for breast, colon, cervical via the pap smear. And for former and current smokers, there are CT scans for lung cancer, but there's no screening for many other cancer types. We're hoping this will be fixed with more updated screening techniques. One of the more promising I'll talk about toward the end of the talk, called circulating tumor DNA. What's your lifetime risk of developing some type of cancer? For men, it's 1 in 2, and for women, it is 1 in 3. And you can see that for men, for instance, prostate cancer is fairly common, 1 in 7. Esophageal, much more rare. For female, esophageal is quite rare, actually. But breast cancer is much more of an issue, 1 in 8. And so you can sort of see these different rates across both men and women. What are the trends on survival rates? So it's interesting. If you look across here to the right, and again, much of this is from the American Cancer Society, but if you look to the right, you'll see that the percent of people surviving, it used to be 50-50 back in the 70s. And now we're basically at 70-30. So the rates of survival have risen. Of course, we'd like it to be up to 100%. And the slope of the rise has kind of settled out a little bit the last few years. So this is something we certainly need to pay attention to. Some cancer types we've made great strides. So breast cancer, used to be 75%. Now, 90% will hit a 5-year survival. Other ones, not so much. So, for instance, lung cancer has only gone from 12 to 18. Not a ton of progress in that cancer type. Uterine's basically stable. Cervical's pretty stable. Prostate cancer has much higher 5-year survival rates now than it used to. Pancreas is still pretty dismal, 3 to 8%. So some cancers we've made a lot of progress. Much of that is made by just diagnosing it earlier and treating it earlier, and better screening tests. So I just wanted to mention the University of Colorado Cancer Center, because as a resident of Colorado, it's just something you all should know about. So a cancer center is basically a medical institution where the focus is pretty much 100% on cancer. And in the state of Colorado, we really only have one center that's designated by the National Cancer Institute as a comprehensive cancer center, and that's the University of Colorado Cancer Center. And of course, its top mission is to serve the public and residents of the state of Colorado. This is a consortium cancer center and really utilizes many of the large institutions in the state. So for instance, Flint Animal Cancer Center, located at Colorado State University, is one of the larger animal cancer centers in the United States, and treats a lot of companion animals like dogs and cats and other animals. And it's interesting, there are many similarities actually between companion animals and humans, where the study of one can help the study of the other. So many human drugs are repackaged for companion animals, and then we get a lot of insights about human cancers from studying animals. University of Colorado Anschutz Medical Campus, also called University of Colorado Denver, is where the main administrative offices of the Cancer Center. And University of Colorado, which is the #1 ranked hospital in the state of Colorado, is the main clinical trial site. We also work extensively with Children's Hospital, which is also in the Anschutz Medical Campus, and the VA, which is also located on the Anschutz campus. And then moving north to Boulder, that's one of the big research sites, and this is a picture of Tom Scheck, who was a Nobel Prize winner working on RNA biology. So there's 6 sites, there's 4 scientific programs, around 270 members of the Cancer Center. So these are people who are doing cancer research. We have over 170,000 visits annually, and I've listed off some of the recent investments made by UC Health and other partners to try to improve precision medicine, cancer, behavioral health, et cetera. And one of the big things we do is we allow patients to have access to clinical trials and put patients on studies to try to develop better treatments. And we put on roughly 2,000 patients per year. So the Anschutz Medical Campus, where did it come from? Well, it's sort of interesting. The campus used to be downtown on 9th Avenue, and you'll hear a lot of people talk about the 9th Avenue campus now being turned into a lot of condos. And there's this decommissioned Army base called Fitzsimmons. Here you can see it was mostly lawn when this transition was made. And then here's that same building. This is called Building 500. This is where Eisenhower was hospitalized when he had a heart attack. But look at all the buildings that have sprung up. And this actually doesn't even cover all of them, because we're building a 3rd tower here for the hospital. We're building a 4th research building here. And the VA over on this side is completed construction. And there's a bioscience park being built behind here. I'm not going to read all of these, but you can see that the University of Colorado Medical Campus, this Anschutz Medical Campus, there's a lot going on. Nearly 500 million in research awards, a lot of firsts, including the first liver transplant, and vaccines and other things. And there's a lot of hospitals and clinics located on the campus. Also a lot of science and patents and things going on too. The hospital has been nationally ranked for quite a while, and the economic impact of the campus is also considerable. Again, I won't read all of these, but just wanted to point out this little gem that a lot of people really haven't heard much about. And again, here's a picture of the campus. Children's Hospital is right here in the middle. A lot of the cancer research occurs in this building here, and the hospital for adults is located here. And we also have the School of Medicine here, the School of Pharmacy back here. And there's also a nursing school, physical therapy, dental school, and others. In terms of the reach of the health system is also quite large. So there's actually 13 hospitals, 24,000 employees. And you can see a lot of volume coming in and out at these various hospitals, and increasingly trying to put facilities where people live. So there's a new Highlands Ranch Hospital that opened last summer, and the Cherry Creek Medical Center will be opening next week. The University of Colorado Cancer Center serves the state of Colorado. So here we've tracked the state, and we've looked at cancer incidence, new patients, and clinical trial patients through the entire state, basically through every county. Here's where where the campus is, and you can see obviously bigger circles of both new patients and trial accruals right around where the campus is located. And you can see, prostate, breast, lung, colon, melanoma, bladder, all the kind of various cancer types here. It's important to realize that unlike my hometown of Washington, D.C., where you could very quickly drive to very large cancer centers in Philadelphia and New York and Boston, and you could go south to Duke and et cetera. Here in the state of Colorado, we're fairly isolated. And so we're really one of the main cancer centers for the state of Wyoming. We actually take care of people from Montana and northern New Mexico, western Oklahoma, northern Texas, western Kansas, and western Nebraska, because Omaha, where their big cancer center is on the other side of the state. So many patients who live in this region would rather come here to Denver. So we really are serving a fairly large geographic area compared to many of our peer institutions located, for instance, in California or in the mid-Atlantic, where there's really sometimes 10 miles from one cancer center to another. We work a lot with various philanthropy groups, including large national groups like the American Lung Association, the Colorectal Cancer Alliance, and also some more localized groups, the Wings of Hope for Pancreatic Cancer Research. That was actually founded here in Colorado, and one of the co-founders was a pilot, and so they called theirs the Wings of Hope. And so you'll see both national and local groups that we partner with who are advocating for patients and trying to raise money to come up with cures. One of the things we've also worked on is trying to bring all of the providers that someone needs to meet to the patient, rather than the patient kind of going around town trying to meet with everybody. So, for instance, if you have a colon cancer, you might meet with a surgeon and gastroenterologist, and then once a diagnosis is made, a chemotherapy doctor, but maybe you need some radiation too, and all this can take many, many weeks to kind of get all this done. What we've done is basically bring all of the doctors to the patient within 1 week. And the idea is to get a treatment plan done right away and go ahead and start treatment as soon as we can. And so patients will come in and get scans and see our nutritionists and other folks. And then we have all of these groups review the case, have a working lunch, and then we actually meet with patients and summarize their care plan. So it's one of the things that we've really pioneered. And you can see this is just the GI group. I happen to work in colorectal, pancreatic, gastric, and other gastrointestinal cancers. It's a large group of people. We have a lot of doctors involved, and also other people such as nurses and study coordinators and other folks who are quite important for the team. But all of these people come together to try to take care of patients. And we've established since 2012, we're actually up to our 10th multidisciplinary clinic because they've gotten such positive feedback from people. The other thing we found, if you actually look when we work on these multidisciplinary clinics, is, I'm not going to go through this whole table here, but in over 30% of the cases, we'll make a change in the prior treatment recommendation, just showing that that very multidisciplinary specialized care could be helpful to take care of patients. Well, I wanted to touch on the immune system. And it's sort of an interesting history because getting the immune system to attack cancer has been studied for many, many years. And until recently, most of those studies were negative. There was a surgeon actually back in the 1890s who would make these toxins out of bacteria and other extracts to try to get the immune system to attack. And interestingly, this derivative of tuberculosis, BCG, which is like a French name, has been used for bladder cancer for a while. If you put this into the bladder, you get an immune reaction against bladder cancer. Then in the 90s, they started using some of these interleukins and interferons, but these are quite toxic and really didn't work all that well. But the explosion really came in 2011 with the approval of ipilimumab and these other checkpoint inhibitors, which I'll talk about in a minute. So what's a checkpoint? So a checkpoint is a way for the immune system to make sure it doesn't get overactivated. So you can think of this like a balance. So the immune system has to spare self, otherwise it'll attack your own body and you'll get an autoimmune disease such as rheumatoid arthritis, lupus, and Crohn's disease, ulcerative colitis. All these diseases where the immune system is too much turned on and attacks self. At the same time, you have to attack non-self. So if you're getting infected by something, you want your immune system to attack. And we know that it's important for the immune system to attack cancer because patients who get organ transplants who are on chronic immune suppression, will often have higher cancer rates. So clearly the immune system is playing a role. And how is this done? You know, it's not like the immune system has a brain. It's done by these immune cells, and over hundreds and hundreds of millions of years, we've had these very delicate signaling pathways that try to make sure that a cell has that Goldilocks, you know, just warm enough but not too hot, right? You don't want it to attack self, but you want it to attack non-self. You want this balance to be somewhere in the middle. And how is that done? It's done through these protein-protein interactions between receptors and ligands, which can be pro-activating or anti-activating. And one of the key ones, if you're looking at a tumor, is this PD-L1, PD-1 interaction. And this is a negative regulatory interaction, so it's like a brake. And so what these immune drugs do is block the brake. It's as if you're cutting the emergency brake because you want the car to get moving. And so this has been a very important, it's called immune checkpoint inhibitor. CTLA-4 is another one, a very important pathway. So there's drugs that have been approved for these. And then there's a lot of interest in these other ones. We have drugs looking at TIM3, OX40, here's this PD-1, PD-L1 again. And so you can see all of these important signaling pathways. We also have LAG-3 drugs that are trying to get this immune system to kill the tumor. But the tumor is not stupid. And again, the tumor doesn't have a brain, but what these cells do is they express this ligand to the checkpoint and they shut down this immune cell. So it's almost like a policeman, if you're a tumor cell, the policeman's coming up to you with their gun drawn, and you basically take that gun away and send the policeman off and tell it not to attack you through this signaling pathway. Well, what's incredible about immunotherapy is not only does it work, but it works better in many cases than these old chemo drugs. So dacarbazine was used for a long time for melanoma, and it's an incredibly toxic drug. It's one of these drugs that causes low blood counts, and nausea, and hair loss, and all the rest of it. This immune drug really doesn't have that much in the way of side effects. Of course, you can accidentally overactivate the immune system, but these are these survival curves where when you start with 100% of people alive, the more the curve goes down, the worse it is because people are dying. And so you want the curve to stay up here. So this immune curve is better because it's higher than this curve. So more people are alive. The 50% mark is called median survival. And so you can see the median survival here was about 10 months, and then it never even got down to 50% for the immune drug. And the duration of response was much higher. So dacarbazine, a lot of people, even if they initially responded, would get worse pretty quickly. Whereas immune therapy, if it works, it can work for a long period of time. So more efficacious, less toxic, works longer. So that's where there's been a lot of hype about these immune therapies. The Nobel Prize was awarded for this to a guy named Jim Allison, who really championed this approach for quite a long time. And unfortunately, these drugs only work in about a third of patients. And so although it's incredibly hopeful, and we've made incredible strides, we still have a long way to go. And so how can we use personalized medicine? You know, the idea of personalized medicine is that you don't give one drug to everybody, because some patients will respond to one drug and other patients will respond to another. So the idea is to give the right drug to the right patient at the right time. And that's where this personalized medicine comes in. I just wanted to give you an example of that. Deficient mismatch repair, DMMR, deficient mismatch repair colorectal cancer. So these mismatch repairs basically are errors in DNA where we have these enzymes and proteins that repair the errors, essentially. And so it's almost as if it's like your spell checker on your computer. Your computer is going in and sort of helping you fix those errors. And some people have a deficiency in one of these enzymes and proteins that are being used to do the repairing. And so as a result, they have higher cancer rates and higher mutation rates. Well, what's interesting about it is if you look at mutation frequency, and it's sort of interesting, you look at a lot of the cancers that children get, have very low mutational rates. Ewing sarcoma, AML, which is acute myeloid leukemia. These tend to happen more in kids, and the thinking is that the kids don't have enough time to have all these cancers happen. Whereas if you're a smoker and you've spent all your time at a tanning salon, those tumors have way more mutations. Lung cancer, you're breathing in stuff, you know, melanoma, you're in that tanning salon or getting a lot of sunlight. Bladder cancer, because of course a lot of drugs and chemicals are eliminated in the bladder. And so this is the group that tends to respond to immunotherapy. And the thinking is that this cancer cells look very different from normal cells. And so the immune system knows to attack. Well, if you take mismatch repair deficient, again, the editing function isn't working, and you use one of these immune therapy drugs, you find that these mismatch repair deficient tumors, whether they're colon or not, tend to respond. This is a waterfall plot. So you start at 0, they give you treatment for a couple months, and then you measure, and you want to be down here. You want your tumors to be shrinking. Over here, they're growing. We want to be shrinking. And you can see that there's some very nice shrinkage in these patients here. And not only is this true in colon, if you have deficient mismatch repair, it's also called microsatellite high or unstable. Across many different tumor types, sure, colon is one of the most common ones, same with endometrial here, but all of these different tumor types, you actually get these really nice responses. And the duration of response can be quite long. So this is looking at the size of tumors over time. Normally, even if you get a response, at some point the tumors start growing, but look here, this is out like 2 years. And so almost like the immune system is able to have memory, just like you have immunity to things that you got vaccinated against as a child. Your cells will have, immune cells will have memory and be able to keep attacking. Even though these are small percentages, we find this deficient mismatch repair in about 4% of all cancers. Now you might say, well, 4%, who cares? Well, that's 66,000 people we're talking about. So those numbers actually will add up. And even if it's 0.8 or 1%, you add up a bunch of those kind of 1% and stuff. Again, we get to the colon and endometrial cancer being more common, but we see these much higher rates of the little pieces of the pie will add up to a large pie. What about if we combine? So here we have one checkpoint plus another checkpoint. I mentioned this PD-1 and CTLA-4. Now we even get higher response rates. Now even more of these tumors are shrinking. So if we combine immune therapy, it can actually work quite well. So what's going on here in your home state of Colorado? Well, there's a lot of different collaborations and things going on. Dr. Martin McCarter, who's on our faculty, he's a surgeon. So he actually focuses on cutting out cancers, but he also runs a lab. And he has shown that all trans-retinoic acid can decrease immune suppressor cells. And so if you decrease the suppressor cells, you get a more active immune system. So he's been doing a study combining this drug with one of the checkpoints inhibitors called ipilimumab. Dr. Liu is my colleague who trained here at the University of Colorado and then did his fellowship at MD Anderson. He's doing a study looking at these antibody drugs, bevacizumab and pembrolizumab, and then combining that with a pill called benimetinib. And he wrote this trial himself. He's getting some support from the companies that make these drugs, but this is his own idea. And we're seeing some really good activity in colorectal cancer. So in terms of conclusions for immunotherapy, after over 100 years of trying to harness the immune system against cancer, we finally made major advances. And it's so much better than chemotherapy if you think about all the side effects that come along with chemotherapy. We have the success of these checkpoint inhibitors across multiple cancers that I've listed there. But you know, it's important to remember that the vast majority of advanced cancer patients still aren't cured. So we still have a lot of work to do. And here in your home state of Colorado, we're well positioned to make some breakthroughs. We have very strong immunologists and numerous clinical trials. I just wanted to go through, how's a typical cancer treated? Well, this patient was actually seen in my clinic. And what we did, this patient had some symptoms, and when he was having a bowel movement, he'd have bleeding. So we did what's called a PET scan, where we use radioactive sugar to see where cells are burning sugar. And it's eliminated in the bladder, so we expect to see this, but we should not see this. So this was certainly abnormal. And then up here in the liver, now we're higher up in the body. Here's the base of the lungs. Here's the spinal cord, the spine, the ribs coming up here. Here's some muscles, muscles in the back. Here's the esophagus, the bottom of the heart, and the bottom of the sternum. And here you can see in the liver, we have this kind of purplish thing here lighting up, indicating that this was unfortunately a stage 4 tumor. And so it takes a lot of people to treat these folks, because I give chemotherapy, and then we have a liver surgeon do a liver resection. We would generally give more chemotherapy, and then one of our radiation oncologists would work with the physics department to radiate a lesion in the lungs, for instance. And we're relying on our colleagues in palliative care to help us treat symptoms, our nutritionists to prevent weight loss, our genetic counselors to see if this person has an inherited predisposition to cancer, our molecular pathologists who are doing molecular tests to tell us what mutations this patient has, and our endoscopists from gastroenterology, the so-called GI folks, who are putting cameras and scopes in people to actually diagnose these things. Why do we care about staging? Because it tells us where the tumor is located and how that patient's likely to do. We use something called T&M. So T is primary tumor, N is involvement of lymph nodes, local lymph nodes, and then M is called metastatic disease. So M is where things have spread. And we care about this because as you have higher and higher stages, so this is where stage 4 is where it's spread, you can see that unfortunately the survival rates once cancer is widespread is much lower than stage 1, where your survival rates are over 90%. So you'll hear people say, well, what stage was the cancer? Why are they asking that? They're asking that because it makes a huge difference in terms of someone's likelihood of living. You take something like colorectal cancer, we have 14 different FDA-approved drugs. And we have these older, what are called cytotoxic drugs. These guys just basically kill anything that's growing. And then we have biologic targeted drugs, such as these checkpoint inhibitors, this pembrolizumab, nivolumab. And then we've also added ipilimumab, which is against one of the other checkpoints. We also have drugs against angiogenesis. So these are against the growth of blood vessels that supply tumors with oxygen and sugar and all the things they need. And why do we have these different names? It might seem like it's random, but in fact it's not. The last 2 syllables are actually directed by a governmental agency because it helps doctors know exactly what kind of drug this is. So for instance, cetuximab, the ZMAB here, has some mouse protein in it. And so patients sometimes will have an allergic reaction against the mouse protein. So if I hear about somebody in my clinic getting an allergic reaction, I want to know if they're on a ZMAB or a Zumab or a Mumab, where there's very little mouse protein in these things. And so these are basically fully human antibodies. Now, we might not be curing everyone, but we're making a lot of progress. If you look at survival in months, as we had no active drugs versus one drug versus a couple drugs, these are all just combinations. Don't worry about what these all mean. All I'm saying is it goes from no active drug to one drug to multiple drugs. You can see that the survival actually gets much better as you add more things. Now with angiogenesis, the idea is that these tumors, here's a tumor, it wants to attract this blood vessel. So it secretes all of these factors to attract the blood vessel and give it a nice blood supply. So we'd like to block that if we can. And one of the ways we block it, if this is a cell membrane, you have these receptors. There's different types. There's vascular endothelial growth factor receptor 1, VEGF receptor 2, VEGF receptor 3. It turns out a lot of the action is in this VEGF receptor 2. And you can block the ligand that binds to this receptor, and you can also block the signaling. And so some of these drugs will block the receptor here, some will block the ligand, and some will block multiple ligands. This one is called VEGF-A. You also have VEGF-B and placental growth factor, or PLGF. if you look at what's the effect, so this was looking at one of these drugs, this one's called aflibercept plus chemo. Don't worry about what this chemo is, but you can see that unlike immunotherapy, we're really not flattening that curve. The curve is still going down. It's a little bit higher, so it's providing some benefit, but it's not sort of as revolutionary as immunotherapy has been. And you'll see these survival curves really across all of cancer therapy studies. The other challenge is that it's hard to afford all these drugs. So this is the cost of a 2-week supply for an average sized person for some of these drugs. And you can see here, over $7,000 for just one dose. The good news is people are living years and years. The bad news is that the cost of these things is becoming fairly prohibitive. And it's for the folks who pay the bills, the agencies and the insurance companies, and of course, we end up paying this, right? Because we pay insurance premiums to get health insurance. These can be quite expensive. I just wanted to mention circulating tumor DNA because I'm hopeful that by the time you guys are adults, we'll be able to use this to make sure that you don't get cancer. And the idea is that if you have a tumor, it's going to release some DNA. All cells release a little bit of DNA. That's our genetic code. And you have normal DNA, but you'll have some of these little bits of circulating tumor DNA. And there's a lot of different things you can look for. You can look for mutations or copy number alterations or fusions where you're fusing one gene to another, or methylation where you have these chemical alterations called methyl groups attached to the DNA, which isn't normal in many cases. And so you can actually, with a simple blood test, you can actually try to detect cancer. And that would really be revolutionary because if you have a highly accurate blood test, it makes a big difference in terms of trying to diagnose people. So this is just an example of how powerful this is. So these were patients who had a colon cancer removed, and the ones that had circulating tumor DNA negative, remember I told you it was very good to be at the top of this curve, you're near 100% survival, they did very well. The ones who were circulating tumor DNA positive, fortunately it was just a subset here, this is the number of patients, so most of them were negative, but some were positive. They did not do well. And so this just shows you that you can detect the presence of cancer by looking for this circulating tumor DNA, and all you have to do is a blood test. So in summary, we've come a long way in eliminating cancer. There's certainly a lot to do. We have a lot of scientists working on better understanding the molecular events, the mutations, and the signaling pathways in cells which lead to this disease. It would be great if we could prevent cancer in the first place, or if you are going to get cancer, if we could detect it early and just get rid of it before it causes any problems. Unfortunately, sometimes it spreads and we need to come up with more effective systemic therapies. And if someone is a cancer patient, we think they're best taken care of in a multidisciplinary, in other words, multiple disciplines like medical oncology, surgical oncology, radiation oncology, et cetera, who are specialized in their disease type. And we think the Anschutz campus is an excellent place to attack this problem. Again, just to show you, this is that building 500 I mentioned, the original Army base. And then these are many of the different schools that are available to residents of Colorado and residents of other states to come train and learn how to be a doctor or a nurse or a dentist or what have you, to attack cancer and other health problems. And so we continue to recruit top talent from Colorado and also from across the world, trying to build these cutting-edge clinical programs and discover the next cures. Education is a big focus because of the School of Medicine, the School of Pharmacy, the School of Physical, we have a PA school and the School of Physical Therapy, et cetera. All these things are important to educate the next generation and to continue to build our reputation. So I'll end there, and thank you so much. And I'd be happy to take questions through email, and I'll work with Chris on that.
Perfect. I'm going to